So you've heard a lot this morning about different types of omega-3s, different molecules, different levels of dosings, timings, etc. And we're entering an era where, in fact, it turns out that these omega-3s are going to be more powerful than just about any other molecule so far in terms of the different actions and preventing death and acting on regeneration. The very brief thing I showed you on diglyceride, I didn't show you a slide that if you look at different rodent models and many other compounds, for some reason, the diglyceride structure, 2 omega-3s on a glycerol backbone instead of usual 3, provides about 2 to 3 times greater neuroprotection in different rodent models than any other kind of molecule. So there's lots of things happening. We're very excited. And one thing I have to say, Glenn, I owe you a formal apology because I wasn't used to the timer here in front.
Don't worry.
And we actually did cut off 5 minutes of specific questions that should have gone to Glenn.
I guarantee you I'll make it up to everybody by talking too much later.
Okay. So why don't we open up this unstructured session? Who wants to go first? There you go. Whoever shouts louder.
Yeah.
This is a question I would have asked Glenn if I had had an opportunity to do so at the time. So what fraction of the dysautonomia, or whatever the word is, cases that you've looked at are preceded by a viral infection?
Well, it's a very hard question to answer, but I would venture to say about 2/3 are preceded by some event.
A known viral infection or something else?
Well, people get sick. So DaCosta said diarrheal illness or fever. What we look at is people come in and say, I was fine until such and such, or I've always had this and it got much worse after such and such. And the such and suches are often illnesses of some sort. So I work in a chronic Lyme clinic, and you see Lyme disease patients. They look just like the other patients. And I've consulted on the COVID clinic, and they look just like the Lyme patients. And then a week ago, I had a young woman who was fine until she got mono, and now she is not herself. And she's rapidly developing this dysautonomia syndrome. We're watching it grow kind of before our eyes as one system after another gets screwed up. She had always had low-grade constipation and always had low-grade depression. She's a girl with a straight A average but never liked school and skipped school all the time. And she's a compliant person. So she was clearly had some premorbid condition, but suddenly had an illness and got worse. She had mono and got worse.
So this obviously suggests that the conditions, the viral infection or whatever, caused the dysautonomia. Is that your conclusion?
My conclusion is that the immune overreaction to the viral illness causes the dysautonomia, and not the virus itself, because all these viruses are very different in their interactions.
Right.
But you get this final common pathway of autonomic dysregulation, and there's also often an accompanying peripheral neuropathy that you can see with skin biopsy. So I think that what happens is you get a viral illness, and then if you're the right person with the sodium channel vulnerability or a genetic tendency to over-metabolize your lipids or some other thing, that you're going to be one of the people who develops this overactivation of sympathetic nervous system, immune system, depletion of dopamine activity in your brain, and gets into a cycle of increasing dysfunction that you can, surprisingly, people, when I get them better on drugs, they don't stay better unless they stay on the drugs. So there are a group of people who get this, who get better spontaneously. If it lasts longer than 2 years, most likely you're going to have to stay on medicine. But before that, if I give you drugs and you get better, at 2 years, I sometimes can take you off the drugs and you'll do fine. The other people tend to stay with. So it's got all these different facets.
I'm going to suggest that we go on to
yeah.
another topic, because we can do this at lunch, and we won't have enough time if just we do that. But there may be other kind of questions for your 5 minutes. There was a question there.
For the DHA...
Can you please give your name first?
I'm Michael Dansu. I have a quick question on the DHA and spinal cord studies. Are there possible synergistic effects with EPA, with simultaneous administration?
Yeah, this is an excellent question. We have also published a small study we did with EPA only, and we did see some protective effects. This was just a very limited study we did with EPA, and we didn't pursue this extensive characterization of the profile of EPA in spinal cord injury as we did with DHA. EPA is quite different from DHA. In terms of generating very rich family of SPMs, there is no doubt it's a very exciting molecule. But from other perspectives, we still don't fully understand some facets of what EPA does in the central nervous system. We have never injected DHA combined with EPA. So I would reserve judgment. I don't know if it would have the same efficacy. It certainly activates, in terms of receptors, for example, some of the targets that could be relevant, because DHA binds to retinoid receptors, RXRs, which can homodimerize or heterodimerize with PPAR receptors, and EPA can also bind to PPAR receptors, which are involved in the neuroinflammatory response. So yes, it's a story that may be quite interesting to pursue, and
it's
it has.
because DHA, in addition to being a functional fatty acid, is also a structural fatty acid. 50% of the retina is DHA.
Yeah.
And we've done both. And in triglycerides, EPA doesn't work, and the diglyceride works. But the other thing about EPA that may be important in a lot of the conditions we're talking about is there's mood, depression, suicide, it's associated with, and EPA has been shown to be much more effective than DHA in prevention of bad moods, suicide disorders, depression, etc. So maybe their combination has some kind of interaction in these kind of conditions we're talking about that may be helpful long term.
This is Mark Lupa. I'll preface this by saying I'm not an expert in this. It might be a silly question, but you know, omega-3 and DHA has been around for so long, and you can buy it at almost any nutraceutical store. And a lot of people have taken certain subpopulations have been taking quite a bit of it, and so I'm just and I presume there have been done some studies in order to look at the things that you've been looking at. I don't think that I've ever seen such striking results, and I'm just wondering what is the difference? Is it a formulation question? Is it the route of administration? Is it a dosage, or is it just better experimentation that has gotten to this point?
Yes, that's a very good question. In fact, what you are implying in a way is saying, well, many people around the world are taking some capsules of fish oil, and maybe there have been studies giving people some fish oil, so how come that this hasn't been shown? Now, when you inject DHA in the peripheral compartment through intravenous access, you have a completely different pharmacokinetics, and you have access, especially through a disrupted blood-brain barrier, which happens after neurological injury, to many receptor targets that you can activate directly and immediately. And that is why we always do in our group intravenous studies, because they are relevant, they are easy to implement by emergency teams, for example, if they want to inject DHA. So I think there is a problem of access of critical targets in a timely manner. Whereas if you take DHA as capsules, and it depends on the level of supplementation, and that's another discussion we can have, most people don't take enough anyway, because a large fraction of the Western population is in a state of omega-3 relative depletion compared to what they should be at. And this is another story. I don't want to digress, but maybe we can come back to it. But just taking fish oil capsules, a moderate dose, will gradually enrich your membranes in cells, in circulating cells, leukocytes, as much as in tissues. But this is completely different from the dynamics of the effect when you inject the drug after an injury. Completely different in terms of access of targets to a ligand.
And I think I showed a slide about we can do it in minutes rather than weeks with an injection. I think, Ru-Rong, you have a point?
Yeah, and I just want to follow up. Certainly, DHA, EPA, omega-3, have been there for a long time now, and the clinical trial result probably not very convincing, right? Maybe we need to identify specific conditions, right? And now, as I mentioned, in DHA and the fish oil with SPM, right? Certainly, those products are much more expensive, right? And in general, they may have a slightly better effect, right, if you can afford it, right? Many of you may be able to, but we still lack of clinical evidence. Another thing I'm thinking is your lifestyle is important. When you take fish oil, if you do exercise, because and as we know, that in the autonomic dysregulation, right? But exercise and breathing, right, will help in a balance and autonomic function. At the same time, if you take fish oil, DHA, it may help in a conversion, more effective conversion to SPM. And in that case, you may have more benefits, right? But I know, that in a surgery, right? So theoretically, if you have a trauma and a procedure, you take, but your doctors will argue against this because, we're causing a blood thinning, right? You're not supposed to take, take fish oil, right? But otherwise, it may help you, and speed your recovery after a surgery and an insult. I would say, DHA, EPA, maybe the most effective time window is in that time window, right? So that's a perisurgical area when you have a lot of information, I think. But in the chronic phase, it can be much less effective. Maybe it's time dependent. Yeah.
Larry again. It's on.
Yeah, it's on.
So maybe for Scott and Glenn, as opposed to focus for the moment on DHA, and as we are a little bit, it's fine, I want to ask whether either of you has ever thought for pain reduction, because I can't remember your big slide of all the things you tried that failed with this one patient and the 6 that worked. Did you ever try the anti-transplant rejection drugs as a way of diminishing the immune reaction?
Yeah, so we do. We've used, again, I collaborate with a rheumatologist for those patients. We've given people, if it exists, we've given it to somebody for their immune system. What's interesting is, again, we're still in the dark, so we don't know which drug to give. So we have some patients who have some markers, and we give them biologics, tumor necrosis factor inhibitors, other things. A lot of our patients have had trials of hydroxychloroquine and methotrexate because they're really benign things to do, and some of them get way better. One of the patients, so I noticed Otsuka is one of our sponsors. one of my patients worked with Otsuka, and she had a dramatic response to hydroxychloroquine, and it was astounding to her. So sometimes those drugs work phenomenally well, Cytaxan and mycophenolate. We use them, but we use them only if we're really convinced that it's mostly immune, because neuromodulators, the nice thing about them, you stop them and they go away. Immunomodulators, you stop them and the immune system doesn't always go back to where it was. And so I worry about that with patients and tell them that we're trying neuromodulators first unless I'm really convinced. But I don't know what the right thing to do is.
Scott?
No, I don't have personal experience with neuropathic pain and those type of drugs. However, as we've discussed before with our proteomics and so forth, that there does appear to be an autoimmune response going on in the injured spinal cord. We have analyzed this tissue a year out, 20 years out, 40 years out. Mm-hmm. And when you look at the proteomics, it's very consistent with markers you see in other immune states, whether or not it be lupus, multiple sclerosis, rheumatoid arthritis, and so forth. So I was interested when you said hydroxychloroquine and other things like that. Those are things we had actually talked about in our group for neuropathic pain. Right. Because something with the initial injury, even if it's peripheral nerve, it's all happening, from my perspective, in my research, at the central processing areas that become hyperactive. Why do they become hyperactive and stay so year after year after year? And then I'll watch this front ascend the cord and descend the cord. One area dies out, then the next area becomes hyperactive. We can actually track this. And then it looks like, to me, that it's an autoimmune response at some level.
So Scott, you had one slide where you went from the spinal cord and you went up to the brain. And so how does it get to the brain? Does it creep along the other part of the nerve pathway, or is it a humoral response?
You mean how does the pain get to the brain?
How does the brain get changed in terms of its sympathetic centers?
After the surgery, yeah. Why does the connectivity change? Well, it seems to be a sympathetic sympathetic response at some point after the injury. There has to be some rewiring of the circuitry after the injury that's now bringing in the sympathetic nervous system, I think at the level of the intermediolateral cell column of the spinal cord. The dorsal gray and the intermediolateral cell column are very close, and you get the C fiber sprouting, and a new circuit develops after the injury that allows for the dorsal gray matter to feed into the sympathetic chain. And we don't know where all the sympathetic fibers come in. When I talk to neuroanatomists all the time, it's hard to track. They're mostly C fibers. How do you track the afferents coming into the cord up into the brain and so forth? So it's a hard question, but it seems to incorporate the sympathetic nervous system in. Then that feedback into the brain seems to shut down communication between sympathetic centers. I saw some slides that showed the insula, amygdala, anterior cingulate cortex, medial prefrontal cortex. I don't remember whose. Maybe it was your slides. Yeah, your slides. We were showing how that talk between those areas and the somatosensory cortex were shut down in the pain state. And then after we eradicated the pain in these patients, they started talking to each other again. And so the sympathetics are involved. Exactly how it gets there, I can only guess that it's a redevelopment of the circuitry from the dorsal gray hyperactive regions. I'm thinking it involves the intermediolateral cell column, sympathetic chain, I know at some level, and gets back up there. I guess I didn't answer that very well. But.
Well, it's a big question. We have a lot of questions.
Yeah, I have one from the audience, from the online audience.
Please.
So this question, and I'm going to elaborate on it a little bit. The question is, do omega-3s interact with non-receptor proteins to modulate their activity? And I think we can generalize that a little bit. One of the things I was surprised to discover as talking with Bob Murphy some years ago was that there are more biologically active lipids than there are proteins. There's tens of thousands or hundreds of thousands of them. We don't really understand their metabolism very well. It's hard to even write them down in coherent ways. So could you talk a little bit about the enzymatic pathways and the regulation and sort of the broader context of what we know and don't know about fatty acid regulation?
So actually, that's very important, because there are more in lipids, right, than proteins. And now we know many diseases are associated with lipid dysregulation, right? Even diabetes. Now people think there is more evidence that is the lipid dysregulation, versus glucose, right? Because and we know that for sure at high concentration they can interact because these are lipids, right? And your cell membrane is basically a lipid, right? And when you have high concentration, they can interact with, for example, ion channels, right? And as Adina mentioned, the potassium channels, and we also show the trip channels, right? So that they can, in that lipid raft in the local environment, they can direct and regulate these ion channels, their distribution and their function, therefore. And then, of course, you have specific surface receptors, right, GPCRs. Then these lipids can also go inside. They have nuclear receptors, right? So that they can interact with mitochondria and boost your energy and production. So there are many pathways, we still don't know much about, that, yeah.
But I think it's an exciting time in that what we're doing in our different labs, we hope that next year we'll be able to come with more specific answers, redose, reroute, and which type. And there's another question here.
Well, mine's more of a generic kind of a
Could
follow-up.
you state your name, please?
Christopher Lundy. Tacking off the gentleman up the stairs there. It's just, maybe this is for a panel next year, but it was kind of like for Alzheimer's and dementia. And I know there's a medication Aricept, and that's maybe to help oxygenation of the brain. And I was just wondering what the future might hold in that regard as far as the cognitive aspects, because most people are taking the alpha-lipoic acids for the brain cognition, the DHA. And so I was just wondering if, whatever kind of layman's comments we might want to have in that regard. So again, thank you very much.
So I've got an answer, but one of you like to take it up? Cognitive aspects, I guess.
Is your question more focused on the potential role of these fatty acids in neurodegeneration and in diseases like dementia and the changes in cognition you see in dementia? Do I understand that correctly? Again, I think the field was started with over-enthusiasm, because if you look at the brain of Alzheimer's patients, there are changes in lipids which are significant, in a variety of lipids, and there is certainly a loss in DHA specifically. We don't fully understand why that happens. There are 3-4 possible causes, and there have been attempts to address this by providing moderate doses of DHA to people with dementia, but I don't think there has been any resounding success with that, because I think, again, it's a question of remembering the complexity of the human context versus studies which are maybe suggesting potential in lower species. In Alzheimer's disease, I think we are still far from understanding what happens over 15 or 20 years, which is silent, and then becomes apparent in the prodromal phase, the mild cognitive impairment, and then.
But
when the diagnosis is made and you give people a moderate dose of DHA or DHA plus EPA in a standard fish oil capsule, I don't think that is enough to see a significant improvement in cognition. Although some animal studies, I think with rather simplistic models, suggest that there might be scope for that. But there is certainly an importance of DHA and EPA for normal cognition, because they have important structural roles. So when you deplete, when you create a state, which you can do genetically or through dietary manipulation, if you take a rodent, again, regressing a bit to perhaps lower species with less complex brains, if you create a state of depletion of omega-3 fatty acids and you do cognitive tests, you see there is a poorer performance. The opposite is true. Zhang Kang created this miraculous little mouse called the FAT1 mouse with high levels of omega-3 fatty acids in the body. And if you look at the performance of these animals, they seem smarter. So there is some indication that being what I would call omega-3 adequate, at least adequate, so not being
No, but I can add that we've published actually in using neonatal models of hypoxic ischemia, like around delivery, called hypoxic ischemic encephalopathy models, that if you treat them after the injury, just after, with the omega-3 injections, that when they grow up to be adult mice, they actually have a normal function. So, and which includes cognitive function tests. So we've published on that. And I'll ask one last question because according to the timer, we're over.
Wow.
To Glenn, in your experience with these multiple inputs to chronic pain, when it's treated, the ones that affect cognitive function, how much does the cognitive function improve?
They go back to baseline, but it takes a long time. So the brain fog is the last thing to go away, and it takes months for that to really get back to baseline. People have to be patient with that part. But they all have, my patients all have created brain fog. A subset of people with familial dysautonomia and have cognitive complaints get better when you give them high doses of niacin via true Niagen, which is a B3 vitamin made into NAD. The pathway is to NAD. And I think it helps their neurons work better in that group of people. So occasionally I'll have a patient where I give them true Niagen and they have a miraculous result. But it's not most people, it's just some people. But I like that because B3 is pretty benign. So more on B3 next year.
So great. So I would like to thank Larry and the organizers for allowing us to be a bit of a pain. I'm originally a gastroenterologist, so you can pick your location, a pain. And I want to thank the speakers, and I want to thank all of you for a special session.